based on the IOTA guidelines. Very often, all of us, all over the world, get reports that say complex ovarian or complex adnexal mass, and this in the final impression. And this does not help us with management. I'm sure all of you all have read reports that say complex mass correlate clinically. Complex mass suggests MRI. Complex mass suggests CA125. So that person will run from pillar to post with no diagnosis. This is not acceptable because it doesn't help us with management. It doesn't tell us whether this mass is physiological or pathological. If pathological, do I treat it medically or surgically? If surgery, what type of surgery? Do I do laparoscopy, laparotomy? Do I call in a cancer surgeon and so on? With ultrasound, we should be able to describe the morphology of what we see using standard terminology. We must try and determine the organ of origin if possible. In some cases, we are very confident about the histology. For example, if we see a typical dermoid or a typical endometrioma, but in all cases, we must try and say whether it is likely to be malignant. Why do we need IOTA guidelines? First of all, to describe what we see using standard terminology so that we all understand each other. When I say this is a multilocular solid mass, it should mean the same to you as to anybody else. If I measure a mass to be 620 cc, it should measure the same when you measure or when anybody else measures. It is only then that we can compare our scientific studies, that we can pool in our data, get some meta-analysis and improve diagnosis going further. This was given to us by the IOTA group way back. Not a part of IOTA, but it is very important to see, is it arising from the tube, is it arising from the ovary, is it an intestinal mass and so on. I've briefly discussed that. And then once I've seen the mass and where it is likely to be originating, my next job is to see, so what it, and I can't go into this because this is a 3 hours talk by itself, but I'll explain to you what pattern recognition means. And that is fantastic, but in the hands of an expert. So this is something we will very briefly touch upon. A way of evaluating adnexal masses where individuals with limited knowledge or experience can do it. And this was given to us by the IOTA group through their various IOTA models. I'm not going to go into all of them. We will only look at simple rules, easy descriptors, and the Adnax model. So let's start off with the first thing. Before I start, I repeat, like I do in every K patient with gynae, please do a transabdominal and transvaginal scan because there is some information you get from transabdominal which you won't get from transvaginal. There's some you may get from transvaginal. Adnaxeal lesion. It's an adnexal mass or a part of an ovary which is inconsistent with normal physiology. Here you see I have a circumscribed hyperechoic mass with acoustic shadowing, a dermoid. A dermoid is not a part of normal physiology and therefore I can call it a lesion. Here is a mass which is circumscribed and this is a corpus luteum. A corpus luteum is a part of normal physiology and therefore it is not a lesion. What is solid component? A structure that has echogenicity and is suggestive of tissue is solid component. Doppler flow confirms the presence of solid tissue. If I see something echogenic and I see blood vessels inside, I am 100% sure it is solid tissue. I can have a mass with no solid tissue. Of course, I have to walk in and out upper tissues lying in the center of the cystic areas. I can have a mass with solid tissues next to the cystic area or I may have a completely solid mass. Remember, solid tissue means there's a higher likelihood of malignancy. Now, not everything echogenic is solid tissue. Clot, debris or amorphous material in a cyst and the echogenic identify hemorrhagic cysts because of two reasons. Very often they come to me from the oncology department saying that this patient has a complex cyst with solid area and septate and all it is a clot inside. Secondly, it is a very common finding. Women in the reproductive age group in the secretory phase very often have a hemorrhagic corpus luteum, and imagine every time if they have to rush to an oncologist, it is a real mess. We should be able to identify that this is just a simple hemorrhagic corpus luteum. So how do we know that this is a clot? First of all, when we apply pressure and we release, it may show jelly-like movement. Secondly, and more importantly, you will never see flow inside a clot. You see flow in the walls of the cyst, but you may not be attached to the entire length. and its appearance changes with size. So even if you call her back 10 days later, so they say if you have any doubt whether it is solid tissue or not, please consider it as solid tissue because of malignancy. Now what is a papilla? A papilla is a solid tissue that is protruding into the cavity from a cyst wall or a septum, which has a height of at least 3 millimeters. So you may have a cyst with no solid tissue, or you may have a mass with solid tissue. This is a papilla, and this is how you measure. You measure the maximum height, but you do not include the cyst wall or the septum from where it is arising. So it should be at least 3 millimeters in height to call it a papilla, and all papillae are considered as solid tissue. Now, presence of papilla means there's a higher likelihood of malignancy. Now, sometimes you may see small solid tissue protruding into the cystic area, which has a height of less than 3 millimeters. Do you know what it's called? Irregularities. So IOTA calls these little projections as irregularities. They can be seen in a variety of conditions, but they are very common in a hydrosalpinx where they represent compressed tubal mucosal folds. And in one particular cross-section of a hydrosalpinx, typically you see 3 of them, something like a therefore sign. A septum is a thin sheet of tissue running across a cyst cavity from one internal surface to the other, with no septum inside when it's called unilocular, or you can have a mass with one or more septae when it's called multilocular. When we call a mass multilocular, that means there is at least one complete septum. Now sometimes you need septum. When you have an incomplete septum, a mass or a solid mass, we look at the outer walls, and if you're looking at a cystic component, we look at the inner walls. So here is a solid mass, you see the walls are regular, and here is another solid mass with irregular walls. Irregular, this was a ovarian fibroma, serous carcinoma. Irregular, more likely to be malignant. Similarly, when you look at the cystic component or a cystic mass, you look at the inner wall. This is regular and this is irregular because of the presence of papillae. This was a borderline serous tumor. The moment you have papillae, the mass by default becomes irregular. Irregular, again, more likely to be malignant. Then we move towards black. It can show low-level echos. It may be ground glass like we saw in endometriomas. It can be hemorrhagic, something like a cobweb or a reticular appearance. Or you may have mixed echos with hyperechoic, hypoechoic or malignant. But they are more useful in characterizing these masses into various histopathologies. For example, if I see ground glass contents, I'm thinking more into echos beyond the sound absorbing structure. And so you see this is shadowing, this is shadowing. It can be seen in a variety of conditions, but it is typical of 3 benign masses. One is a dermoid. Here is my probe, here is the echogenic fat and hair and sebum. And you can see beyond that, I cannot even see the posterior margin. This is acoustic shadowing. Again, it is seen in fibromas and behind the papilla of a cyst adenofibroma. Presence of acoustic shadowing increases the likelihood that the mass is benign. Now, just based on these two, a single cavity, unilocular, that means a single cavity, no solid, multiple locule and solid tissue. You can have a mass which is multiple locules and solid tissue, or you can have a solid mass. Now here you see that the entire mass is solid, but according to IOTA, if 80% or more of the mass appears solid by your subjective evaluation, so you take your probe, go up and down, left and right, and if I feel it will also be solid according to IOTA, even though I see 2 cystic areas within. Any mass with more than 80% of the mass is solid tissue, according to IOTA, is a solid mass. So you will see, moment there is solid tissue within a mass, the likelihood of malignancy goes up. And if this solid tissue is heterogeneous with irregular margins, then the likelihood of malignancy becomes even higher. Now we come to Doppler or color. So Doppler evaluation of masses for color signals. Minimal flow is color score 2, moderate flow is color score 3, and abundant flow is color score 4. One thing I want you to remember from today's talk, that is Doppler color scoring in some of the iota models. So if I have a mask with a color score of 4 and I increase the PRF, I can make it color score 2. If I have a mask with color score 4 and I decrease the Doppler gain, I can make it color score 2. So I cannot do color scoring unless I have done proper Doppler setting. And secondly, and more importantly, Doppler flow, presence of flow confirms solid tissue. Centimeter endometrioma was on treatment for infertility. They did a partial cystectomy because they wanted to retain her fertility, and the histopathology report came as endometriotic cyst. Then what happened is they looked at the, endometriotic cyst. Now this patient came to me 3 months later. That's when I saw her for the first time, and I was surprised. Of course the cyst had filled up, but there was this large solid papilla with irregular margins and central flow. You see, I've used color Doppler because this is an old case of mine. Today I would use power Doppler or HD flow. That time I didn't know. And you can see this told me that this is very likely to be malignant. So we told the patient, and before that I went back to look at the images that were available, and I was surprised that this part was actually also seen in the previous scans, and it had been interrogated with Doppler, but the problem was the Doppler's PRF was 1.3, so it was reported as a clot within the endometriotic cyst when actually it was solid tissue. So in this case, this patient got operated and it was an endometrioid carcinoma grade 2 arising in a background of endometriosis, because you know they can bleed inside and they can have clots. Whenever you see a hyperechoic area, please look for, because we don't know whether it's solid tissue, it's amorphous material, or it is a clot. We should assess that area with Doppler, but with appropriate setting. What is ascites? Any fluid which is outside the pouch of Douglas according to iota is ascites. If you have fluid behind the uterus, that's okay. But if you have fluid above the uterine fundus or anterior to the uterus, then that according to iota is ascites. How do you measure a lesion? Now this is also very important. You must measure a lesion in 3 orthogonal dimensions. For this, you need 2 images of the mass in 2 planes that lies horizontal to the ultrasound beam. So I try and get my maximum. So if I'm getting a big mass here, I move my probe a little bit here so that the maximum measurement comes horizontal to the beam. I freeze that image. The next image, I do 90-degree rotation and I get it in 2 planes that are 0.523, and you will get the volume. It is only volume that will help you see whether this mass is growing or regressing. Some years back I told everybody I was flying from Bangalore to Delhi and I was working on my. So you must measure 3 dimensions, get the volume to know whether really a mass is growing or regressing. Now according to iota, some of the models we require maximum diameter of the mass. For this, what do? I again take my probe, I go all around the mass in all directions, and wherever I can get the maximum possible image dimension, I freeze that image like this. And it doesn't matter horizontal to the probe, left, right, whatever maximum dimension I get, I freeze and take that image, that measurement. Third, they want us to take maximum diameter of the largest solid component. So again, I go around the mass, wherever I feel the solid tissue, I'm getting a maximum dimension, I freeze my image, and I take the maximum dimension of the largest solid component. Describe what we see, we describe, and we measure. But next we look to the origin of mass. I'm sure all of you do ultrasound. The first reaction when you see an Adnaxeal mass is it ovarian or not? Where are the ovaries? So you see there's a mass on the pelvis. I look carefully and I see both the ovaries are far away looking normal. So I know that this is not an ovarian mass. It was a gastrointestinal stromal tumor of the jejunum. So it was a jejunal intestinal mass, a gist of the jejunum. Here again I have a patient with a cyst. The ovaries are seen far away normal, so I know it's not ovarian, it's a paravarian cyst. Another lady, postmenopausal, nice cyst over here. She was referred to as an ovarian cyst, but you can see the tissue between this ovary and this cyst. So again I know this is not ovarian but a paravarian cyst. Now if you don't see the ovaries separately, the next thing is to look for ovarian tissue alongside the cyst. So here you see I have a cyst, and when I look carefully I see ovarian tissue around the cyst with small antral follicles, and it's actually stretched around the cyst as if it were hugging the cyst. So this, because of its shape, has earned itself the name of crescent sign. Basically, when you see ovarian tissue adjoining the cyst like this, the crescent sign tells me that the lesion is contained within the ovary, that is, it is an ovarian lesion. Now sometimes you may see ovarian tissue alongside the cyst, but it's not stretched around the cyst, so that is confusing. Is this really ovarian or not? So what do you think we should do? We should apply pressure with a probe between the two structures, and what you see, initially they slide and then the two structures move far apart, and so I know that this cyst is not ovarian. Splitting sign is present and crescent sign is absent. So according to IOCA, crescent sign doesn't mean that the ovarian tissue has to be crescent shaped. It just means that ovarian tissue is actually adjoining the lesion. Sometimes you cannot see ovaries separately, and I cannot see ovarian tissue alongside the mass also. That is very confusing. So you try really hard and you see that there is no right ovary separately, there is no ovarian tissue alongside this lesion. Normally, there is no right ovarian tissue. So you report right ovary is not seen separate from the mass and no ovarian tissue was seen alongside the mass. And this lesion has completely replaced the structure of origin is the shape of a mass. So if I have a mass like this, which is bent upon itself with these incomplete septa, I am thinking in terms of a tubal mass. If I see a mass which is connected with a pedicle to an organ, so I see the uterus, there is a pedicle, I know this is not an ovarian fibroma, it's a subserous pedunculated fibroid because of the pedicle. What about this? This was a very funny mass, like a claw holding on to the ovary. The ovary itself looked okay, but this structure looked, I was wondering if it's an intestinal mass or a tubal mass adherent to the ovary. The moment I took Doppler, I could see flow from the ovary into the mass, so I knew this is an exophytic ovarian neoplastic mass. What about this patient? Here you see this patient, you're looking at the relationship to the structures. This patient was misdiagnosed for 12 months before she came to me. So there was this lesion which was there behind in the pouch of Douglas. The left ovary was seen. Do you think it's entire? Difficult to say, but it looked entire because the shape is like that of the ovary. There are follicles in the periphery, so I felt this looks like it's completely the left ovary lying separately. There was a hydrosalpinx and there was this heterogeneous solid vascular mass. I kept looking around and suddenly I saw in one place this neoplastic tissue was protruding into the hydrosalpinx. So it was anybody? What could it be?
Tubal mass.
Tubal, yeah. So it was a tubal malignancy because solid neoplastic tissue was protruding into the hydrosalpinx. It couldn't. So the main thing is what it is, it should be a secondary problem. First is to see and document with a cool mind. Then you see, oh, the solid tissue is coming in. It can't be anything else other than a fallopian tube malignancy. Moving on from origin is pattern recognition. You know what is pattern recognition? When we are little children, we are taught the 7th dysteaminomas. I say, oh, this reminds me of the other 6 dysteaminomas. May not be the same, but it will bring back memories of those previous dysteaminomas and I will be able to identify. That is pattern recognition. And that is great in the hand literature. We didn't have videos and online that we could see. Today there are so many videos, so much of material online that we can look at 10 dysteaminomas. Even if one is a hemorrhagic cyst. So tomorrow if you have a patient with a hemorrhagic cyst, I don't think it will be a problem to identify because we discussed it in detail. And they are very commonly seen in women in the reproductive age group. Next is an endometrioma, also commonly seen, and we just finished our talk in young to identify at least a typical dermoid. Next is a fibroma. A fibroma is not a common, anechoic, thin-walled, poor vascularity, and with incomplete septae, so you know. So even as a beginner, these are 5 masses that I feel we should be easily able to identify. Now, if you want to know more, there is a beautiful article in the World for Children and Your Family. So IOCA has really gifted us with these models where we can pick up whether a mass is likely to be benign or malignant even as beginners. So the first thing the IOCA group did when they looked at all their masses, they looked at these certain features. They said, oh my God, these features are very typical of malignant masses and some features are very typical of benign masses. We have better models now, and also because it's available everywhere on the internet. Irregular solid tumor means solid means 80% or more of the mass is solid. presence of the size of unilocular mass with no solid benign and none from the malignant, the mass is benign. But if you have few features of malignant and few of benign, or no features of malignant and no features of benign, then we say that the case is inconclusive. Now, they realized in their study that 77% of masses could be categorized into benign and malignant pretty accurately with high specificity and sensitivity. And the remainder for this, one of the IOTA committee members. So we came up with 6 easy descriptors, 4 benign and 2 malignant of an endometrioma. Second is unilocular with mixed echoes and acoustic shadowing in a premenopausal lady suggestive of a dermoid. Next is anechoic unilocular less than 10 cm with regular walls suggestive of a cystadenoma. And the last is any other unilocular, you can see with low level echoes here, with regular walls like this mucinous cyst. So these were the 4 benign easy descriptors. Now I want you to see all these masses are unilocular. If the mass is not unilocular, you cannot apply easy descriptors. Then you have 2 malignant easy descriptors. One is, which is not very commonly used today, but just to complete the easy descriptors. A postmenopausal lady with ascites and at least moderate flow in the mass, that is color score 3 or 4. And a lady who is more than 50 with a CA125 that is more than 100. And they said, we are going to combine easy descriptors and simple rules, and they came up with a 3-stage approach. So whenever we saw the mass, the first thing we did was, can I apply easy descriptors? And they were able to make an easy instant diagnosis in 46.5%. Just one look, it was either a dermoid or it was an endometrioma, so they were able to sort out 46.5%. In those that they couldn't, they would apply simple rules, and another 34.1% got sorted out. And in the last 19.3%, they said you can get the help of an expert, or you could simply consider the malignant, because half of them do turn out to be malignant. So let's do one example. I want you to shout out answer given with right-sided abdominal pain. This is the mass. What are the contents? Ground glass. And this is the echogenic area. What could this be? Very good. Somebody's noticed the shadow, but what do you think this is? And using Doppler, can you see that little flow? Yes. Color score is 2. Minimal flow is color score 2. So I've seen that little flow there. So now I'm sure that this is solid. Perfect. Now I'm sure that what type of a mass is this then? Is it unilocular, multilocular, unilocular solid, multilocular solid, or solid? Perfect. Unilocular solid. So this is a unilocular solid mass, and that she had minimal free fluid in the pouch of Douglas, and there was no evidence of torsion. I'm saying that because she presented with pain. So now let us look at the first stage is easy descriptors. Okay? Can I apply easy descriptor benign? This mass is unilocular solid. Can I apply easy descriptor benign? No, because the mass should be unilocular to apply easy descriptor benign, and this mass is not unilocular. It is unilocular solid. So I cannot apply benign easy descriptors. Can I apply the malignant easy descriptors? No. Why? Because she is just 27. She is 9 tumor. Is this a solid tumor? No, this is unilocular solid. So no. Is there ascites?
No.
No. There's only fluid in the pouch of Douglas. Are there at least 4 papillary structures?
No.
No, there's a single one. Very good. Is it an irregular multilocular solid mass?
No.
No. Is there strong blood flow or a color score of 4?
No.
No. So how many malignant features?
No.
No malignant features. What about benign? Is it unilocular? Is it unilocular? No, it is unilocular model. It was a benign serous cystinofibroma. Now, don't you think this is fantastic? As a beginner, I don't know what this mass is, right? Then the IOTA group came out with this fantastic model, which is called the Adnaxeal model. Adnaxeal on the internet. So you open your laptop, you open your desktop, you can get it. Just right there, the IOTA Adnaxeal model, you'll get it. There are 6 ultrasound parameters and there are 3 clinical parameters. And all you have to do is click on calculate and see what happens. Let's look at this patient. Unilocular patient with a unilocular solid mass. So there was 1 locule and solid tissue. there were 4 papillations. The largest measurement of the largest papilla was 58 millimeters. The largest measurement of the mass was 116 millimeters. So we put in all this information. Age of the patient at the time of examination, 48 years. Oncology reference center, yes, many of these patients come to me from the gynec, all the gynec oncology referrals come to me. So this is where she came from. I said yes, but if you're not doing it, you have to click on no. Maximum diameter lesion was 116 millimeters. Maximum diameter of the largest solid component, I've already measured, this papilla's largest measurement was 58 millimeters. More than 10 locules, you are just yes or no. What would you type? No, right? Number of papillations, the options are 0, 1, 2, 3 and more than 3. So we had to click on more than 3 because there were 4. Then after 4 it doesn't matter. It can be 4, 5, 10, 20. It doesn't matter to the aorta model. Acoustic shadows were absent. Ascites was not there and CA125 was 197. So all I have to do is click on calculate and it's like magic. It tells me the probability of this mass being malignant is 94.5%. That means we are almost certain that it's a malignant mass. And this did turn out as predicted by the aorta model to be a clear cell carcinoma. Okay, now what I did was, if you remove, you remember this even without CA125. So I deleted the CA125 and I clicked on calculate and it says, are you sure that CA125 is not available? The field is indeed optional, but it will decrease the discrimination between stage 2 to 4 invasive tumors and other malignant subtypes, because we know in many of the stage 2 to 4 CA125 value goes up. So I said yes, I'm aware, but I still want to calculate, so I click on yes and it tells me without CA125 the probability that this mass is malignant is 91.2%, with CA125 it was 94.5%. So it was pretty accurate both with and without CA125. This mass is very likely to be malignant even without CA125. So but the difference you see is in the sub-malignant type. Without CA120, 32%, with CA125 it was 45%. So the difference in when you do CA125 is more between the malignant subtypes. So the Adnaxeal model discriminates well between benign and malignant tumors with and without CA125, and it has a fair to excellent discrimination between the 4 malignant subtypes, which is more accurate using CA125. So the Adnaxeal model has 2 purposes. One is it tells me likely to be benign or likely to be malignant, and the second part is it tells me what is the malignant subtype, and this is an advantage. So a patient comes to you, she's not done a CA125 value of the sub-malignant type. So you ask her to do a CA125 which is not done, and then you do. Now when you look at CA1, look at the malignant subtype, it is highest for stage 2 to 4, right? But aorta, this is the patient's, now I want you to pay attention. This is slightly confusing, but if you pay attention, you'll understand. This is the patient specific risk. That means if when the Adnaxeal model said there's a 45% chance of stage 2 to 4, 22.9 of stage 1 and so on. But aorta wants us to look at related risk. What is related risk? When the aorta did their study on 6,000 patients, 68.2%, this is the baseline risk of their study. 68.2% of their cases turned out to be benign, so 31.8 turned out to be malignant, so many were borderline, so many were stage 1 and so on. So this were their study results, which are called baseline risk. And this is our patient specific risk, right? Related risk means how many times more or less than the aorta results of the aorta study group is our patient likely to have a certain type of malignancy. So if you look at patient specific risk, it is highest for stage 2 to 4, same thing, 45%, 45%. But if you look at related risk, it is highest for borderline. So the aorta group has told us when we are looking at these malignant subtypes particularly, it is good to look at the related risk, which is they have found to be more accurate than the patient specific risk. I hope it's clear. So the Adnaxeal model does 2 things. The beauty, you notice one difference with simple rules. Simple rules just told me likely benign, likely malignant or inconclusive. Adnaxeal Adnax model gives you a number for every patient, 32%, 60%, 90% risk of malignancy. So it gives you an estimate, and with that estimate you can actually triage patients into low risk, intermediate risk and high risk. And what is your cutoff should depend on your center. So if in my center I have the capacity to do a frozen section, if I have the capacity to call an oncologist at my beck and call, then I might be able to see cases with higher risk. But if I'm periphery, I don't have much facilities for frozen section, I don't have an oncologist as standby, even with a small amount of risk I may want to send. You need to tailor this depending on your center, and of course you need to tailor it also depending on the patient. So patient comes with family history of breast cancer, she's BRCA positive patient. So in these patients who already have a strong family history, even with 10%, I'll say, you know what, maybe it's better you go to an oncologist. So they say you have to decide your low risk, but generally low risk is taken less than 1%. You can tell, oh, you don't have to worry, we just follow you up. If it is 1 to 19%, for example, if in my center the cutoff is 20% for high risk, 1 to 19%, I tell the gynecologist who is locally present who can operate. But if it is high risk, that is above 20%, that means it's better to send it to a gynec oncologist because they will be able to treat the patient best. Just because we earn money out of surgery doesn't mean we should keep. And even though it is only 30%, I consider a high risk. That means she is high enough at risk to send her to a gynec oncologist. Just like you do NT scan. If in NT scan you tell a patient your risk for Downs is 1 in 20, it is high risk, and the baby turns out normal, well, 19 out of 20 will be normal. So when we say high risk, it doesn't mean that the baby has a problem or this case is definitely malignant. It means it is high enough to send her to a gynec oncologist. And the second thing, it gives you an idea about the malignant subtype. And malignant subtype is not the only reason, but it gives us, it is one of the factors we consider when we are counseling the patient. So obviously she will have other investigations, but malignant, so if you think this is a borderline malignancy, you talk more in terms of fertility sparing surgery, you will talk more in terms of laparoscopy. So this is one of the multiple factors that I use to decide what would be the best management for her. So there are two advantages of Adnax model, some malignant type and also whether it's likely to be benign or malignant, and because it gives us a number, we can triage patients into low risk, intermediate risk and high risk. Now in Adnaxeal masses, first stage they use modified benign easy descriptors. You don't include the malignant, only those 4 unilocular ones that I showed, but it is modified. Now what is that modified criteria? They've added a criteria of less than 10 centimeters because they realize when they say less than 10 centimeter unilocular masses and those 4 descriptions that I gave before, the risk of malignancy is very, very low. In fact, in reproductive age group, it is really, really low. So we are almost not missing any malignancy. So they use modified benign easy descriptors at the first stage, and 40% of the masses could be classified then and there. And in the remainder 60%, they said use the Adnax model. All you have to do is fill in those 9 parameters and click on calculate and it works. So let's start with this first case. Now I want you all to talk. 24-year-old lady with a left Adnaxeal mass, the dimension. This is color Doppler. Can you see? Now when I switch from color Doppler to power Doppler, see what happens. I'm seeing this small vessel that I couldn't see with color Doppler. That's why I said don't use color Doppler. You will miss out on small vessels with low velocity, and it's the same thing with HD flow. This is HD flow. Again, I can see this small vessel that I couldn't see with color Doppler. So look at this mass. Why am I doing a trans-abdominal scan? I do it in every patient, but why am I showing you the true pelvis into the abdomen, right? The true pelvis doesn't have enough space. So it comes up, so the scan on trans-abdominal scan on this patient was better than my trans-vaginal scan. Therefore, I'm showing you the trans-abdominal scan. Look at the heterogeneity of this mass. Look at the margins of this mass. Very, very important. Can you see? The margins, and these margins are best seen when there is fluid. This is fluid in the abdomen, so this would be ascites. Can you see this? And of course, we use Doppler, so we get an idea for pattern recognition. It is good that we see Doppler in every case, and of course, it will confirm that this is solid tissue. And guess what type of a mass is this? Unilocular, multilocular, solid, or solid? Solid mass. Very good. Now, can I apply apply the benign, now what, sorry, now can I apply the, I want to know now this is benign or malignant. So can I apply modified benign easy descriptors?
No.
No, because this requires the mass to be
Inmovable.
and this mass is solid, so I cannot. So I move on to the iota Adnax model. I fill in all this information. You watch. Maximum diameter of the lesion is 134. Maximum diameter of the largest solid component is also 134. Once you classify a mass as solid, both number 3 and number 4 should be the same measurement, even if it has some cystic areas inside. Do you remember that? Once a mass is classified as solid, maximum diameter of the lesion and maximum diameter of the largest solid component will be the same. So I filled in 134 and filled in everything, and I click on calculate. So the risk of this mass being malignant is 85.4. Chances of this mass being benign is 14.6. So do we send her